Our seats so we can go ahead and get started.
Not all of us. Let's just call it
Appreciate you all being here. I'd like to go ahead and call to order the Medical Directors Committee meeting. And I'd like to go ahead and begin by giving a little bit of time to Kathy Perkins, who has some information for us.
Last time I came and chatted with you guys about the Medicare fraud issue that was brought to bear, brought really public in a series of articles done by the Houston Chronicle. And we'd known that the problem existed in Texas, but they really outlined, they did a great, almost a year researching the article. And I told you that my boss considered it a high priority for us as a department to look at what we could do to address this issue. And so I wanted to kind of give you an update of what we have done since then. You are already participating. We have our rules opened. And we want you guys and gals to give us any ideas you have for what we could put in our rules. So that process is ongoing right now. One of the things that I do need to tell you, we talked about CMS potentially doing a moratorium in some targeted counties. That has not been implemented yet. We thought it was going to be by now. But CMS has been crunching some more numbers, and they're really trying to target in on the counties where the problem is the biggest. And there have been some stakeholders communicating with CMS and requesting a statewide moratorium. Well, that could be a problem. And the reason is that what CMS has told me is that if they implement a moratorium, we can't even a new 911 provider in a rural area could not be enrolled in Medicare. So, and one of the things I did when I signed the letter saying that there wouldn't be an access to care problem in these named counties, I put in the letter that I would like an exception if we needed a new 911 provider, and I was told they can't give an exception. So we need to be very careful about having a statewide moratorium. I think it needs to be more targeted. That's my opinion at this point. So there have been discussions going on. I've talked to the Medicaid director who works for HHSC about this issue. They are not concerned about a moratorium in targeted counties. And so I think it's going to happen. It just hasn't happened yet. We also have started to do some things on our initial surveys for new providers. We're asking the medical director to be present at that provider survey. On inspections, complaint investigations, we're asking things like to the medics, do you know who your medical director is? Tell me how you contact your medical director please contact your medical director right now. Okay? So we're starting to do those kind of things. We're working closely with the city of Houston we're hearing things like the medical director said, I'm not your medical director anymore, and then they got paid, and now I'm your medical director again, and by the way, I'm going to cover you for that time when I said I wasn't your medical director, which is, of course, not legal. So we're trying to forge those relationships with locals, and if they hear things and see things, we need to be brought into the loop of that. But the biggest thing that's happened since then is I did go meet with the Texas Medical Board Executive Director. And it was a very, very, very good meeting. We brought to her a list of medical directors and firms so that she could see how many firms had, how many medical directors had 20, 30, 40 plus firms, okay? And we talked to her about the Medicare fraud issue, and she immediately said, well, we're willing to look at our rules to see if there needs to be a cap. So we talked about that because I brought up Dr. Peirce, who has a lot of medics, okay? And we don't want to have a problem there, and we also don't want to have a problem in some of our rural areas where there just aren't that many people out there that are willing to be medical directors for some of these very small firms. And she said we can work around some of those issues, and we'll be, you know, of course, want input from. In fact, I tried to get her here today, and she was not able to because the board is meeting right now, yesterday and today and tomorrow, I think. I'm going to try to get her to y'all's May meeting. So she's willing to look at caps. She's willing to. She likened this to the pain clinic, the illegal pain clinic issues that are going on also in Houston, where you know they're paying docs, or maybe some of them aren't docs, $10,000 to $20,000 per script. This is very similar, she said, when an EMS doc's getting $500 to $1,500 a month per firm that they have under them, and then if they don't get paid, then they pull out they said, I'm not your medical director anymore, and then they get paid and they're the medical director again. But she's also willing to consider the medical director course that you guys have been talking about as a requirement, but there's going to have to be some discussions. She's also willing to consider putting on the application, which is something you've been asking for, that indicates that you are a current medical director. Okay? So it was a really phenomenal meeting. But I think the best part of the meeting for us was understanding something, and I think we understood it intellectually, but didn't understand how critical the medical board considers this issue. You can have the most perfect protocols for offline medical direction, but if a medic doesn't know your name, has never seen you in an education program or a CE or QI, doesn't know how to contact you, then there's a piece missing, and that's supervision. You have to have both. You have to have the online medical protocols, and you have to have that supervision aspect. It's not just of EMS, it's of PAs, it's of advanced practice nurses. There has to be an active involvement of a medical director with their medics. And if that's not happening, then supervision isn't happening. And if that's not happening, then they are not following the current medical director rules. We don't even have to change the rules from that perspective. They're not following those rules. That was really, we're going to talk to all my staff about that issue, and that's something that they will be doing more of, questioning the medics, et cetera, when we do our inspections and those kind of things, okay? So that was a very important aspect that you guys do, and you do it without even thinking about it because it's the right way and right thing to do, okay? But that isn't what's happening in many of these cases. So the other thing that was very interesting is they have no EMS medical director consultants to the board, and they want some, and I've got the information for you guys. They pay $100 an hour, and when they call you to do a case review, if you don't have time, you can say no. Yeah. Oh, and it's anonymous. The case that you review, the person's not going to know. Okay? So we're giving this out to you. We're going to get it to TCEP. We're going to get it to TMA. We're going to get it up on our web, and we want y'all to talk it up too. They need you guys. Not just they need you guys to be giving input and participating in this process there. Okay? Where we're going from here, as I said, I tried to get her to this meeting. She said she was willing. I don't know what's going to happen. I don't know if May's going to come first and we try to get her there at your meeting in May, or if they will start a stakeholder process on the EMS medical director rules in regards to these issues, in which case you guys would be invited to that, okay? So I'm not sure what's going to happen first, but it was a very good meeting. And she looked at that list and she said, there's no way you can meet our rules and have 20 firms and 30 firms or 40 firms. She said that you aren't meeting the supervision aspect likely. Okay? Any questions about that? No?
What was her name again?
I think it's
Emily?
Mary Robinson.
Mary Robbins.
Yeah, M-A-R-I. I think I got that right. Okay, the other issue that I wanted to chat with you about, and I'm not ready to give any handouts yet, but Dr. Emily Becker is the medical director for the state mental hospitals. She works directly for Dr. Lakey. And she presented some information to us just yesterday about drug overdoses, legal prescription drugs. And you may have been hearing about this, but we'll be getting this information out to you when she gets it finalized. But drug overdoses deaths have now passed motor vehicle, and that's astonishing. And many of them are legal. We have documentation of in the last 20 years that the prescriptions for hydrocodone and oxycodone products have increased fourfold over that time. Now, some of them are through those pain clinics, which are not legal, and they're trying to work through that. The current average user is a 55-year-old white male. That's nothing like illegal drug use. Okay, this is a different population. As you see the numbers of prescriptions go up, you see the calls to the poison control network following along the same lines. So you have and it's like this. The lines are increasing dramatically. Also methadone, as well as fentanyl. Fentanyl, the line on fentanyl is like this, okay? So when she was talking about, I'm not sure exactly how the department, number one, I wanted to make you guys aware of this issue, but the department may be bringing together a work group to look at it from the mental health side, from a number of sides, and I said that EMS and EMS medical directors needed to be at the table. You agree? Right. Okay. So when and if that starts I think it will, I will let you guys know. Okay? But it's become a serious. I was stunned about it about this. Overtaking and passing motor vehicle deaths. Isn't that something? Okay, and that's all I had, unless you have any questions. Yes.
No, about that, we in Fort Worth, Tarrant County, there are a few counties in other states that have recommendation or guidelines for narcotic prescriptions, therapeutic narcotic prescriptions. We've been working at that as a county, trying to come up with guidelines. Now, we're also been working with these return boxes, medication return boxes, prescription return boxes. The difficulty is that by state law, those boxes have to be in the presence of law enforcement, which means you have to put them in a police station somewhere, which is really going to inhibit some of the people returning some of the things that they may have or not have. But there is a push. We've communicated with our poison center, and the numbers are up. Our numbers in the county, especially in pediatric accidental. So pediatrics get a hold of these medications, the numbers are substantially higher. So there are movements. I do have some documents from, I believe it's San Diego, these guidelines. I'd be more than happy to send those to you and share you what we're doing in Tarrant County.
Okay. This is the line of the poison control calls on legal drugs. So, okay, that's great. That would be very helpful. I'll share it with Dr. Becker.
Would it be helpful if this committee recommends a doc to serve on the TMB
That's certainly, if you would like to do that, that's
as a committee
fine.
or TSEP or?
You can do that if you would like to. I will, as soon as I get more information, I'm going to get it out to you. I just don't know when she's going to start those meetings.
I think it's probably safe to say that if they called, we would serve. I mean, so.
Let me just also say one other thing. I mentioned this in the MS committee. We are continuing to see a high rate of problems with your medics and drugs, drug diversions, and sometimes it is two medics agreeing Okay, I'm wasting this morphine. Yes. Okay. Not really wasting the morphine. Drug diversions, et cetera, we're seeing continued high numbers of cases. It's very concerning.
Thank you. Any other questions for Kathy? We appreciate you. Let me go ahead and take the opportunity to segue right down to item number 10 regarding discussion of a potential use of a medical director's online course. And for that, I turn the microphone over to Don.
First off, thank you, Dudley, for the clicker. Okay. This is going to be real brief, and I've only got about 60 slides here to get through.
You got 51 minutes.
Okay, nine slides. First off, the problem, as you've already heard, this is a multifaceted problem. One of the big problems that if you've been coming to our meetings for years is we don't even know who all the medical directors are. It's been a problem trying to identify those people due to various problems. We need to be able to communicate with them. There are some items that we discuss here that we need to be able to get out to those people that just can't come here. We also need to educate all of them so that they understand what their role is as a medical director, offline or online. And lastly, and segging into that, is that they need to know the rules that affect them as a medical director in Texas, because I can tell you the ones that I've talked to, most of them don't, unless they're active at this level. And we'll get to the right place here for everyone, because I'm actually doing this off of my computer and on theirs. So what's out there? Right now, there are several courses. I just completed the National Association of EMS Physicians course for the second time. There's textbooks from ACEP, from NAEMSP, various courses such as the one that North Central Texas has, and then others, and then there's also some online courses, including the one that we're going to talk about. The focus on these is very variable, just the same as if you're somebody that's in the tactical world and you go to a tactical medicine course, there's not a lot of uniformity in what you're going to get covered. They have variable presenters, and then the big question is, if we throw something out there that somebody has to come to, will they come? Don't know, okay? The next is a cost, okay? And that's, especially for some of the rural folks, that's a big question. So what are some of our roadblocks? Time, cost, time, the location, and time. A lot of these small rural services, the doctors will tell you, I can't afford to take time out of my private practice to go and take a course in Arizona or Florida when they're having it within NAEMSP or other places. Sometimes they're costly. The one for NAEMSP is an expensive course, and if you don't get CME funds to pay for that, that can be a burden for some folks. Some are free, but still you may have to have a membership in an organization, or it's going to mean time away from your practice. So we're trying to make it less burdensome. So one possible solution. This is a course that is online, and it actually follows the core content, if you can read it up there, of NHTSA and the National Association of EMS Physicians and ACEP. And in this case, you can see that it also has available to them some addendums in geriatrics and pediatrics, and also medical response to terrorism. If you want to go and look at this, you can't really get much further than this particular slide, but you can go to medicaldirectoronline.org, and you can take a look at it at your leisure. This is the actual table of contents, and that if you log into this, that you can see what they're going to cover. There's an EMS overview, EMS systems, medical oversight, personnel and education, system responsibilities, quality improvement, the medical director's role in all hazard events, state, regional, and local issues, and then there's a final evaluation. In this particular case, this company also provides to the medical director, upon completion of the examination, continuing medical education credits. I don't know the exact number of hours that they give. I want to say that it was 12, but I need to get that clarified from these folks, exactly what they get for that. This is produced from the NAEMSP curriculum. Initially, it was a government project and now has moved over to the private side. They offer a standard registration. If one of y'all wants to send your medical director to take the course online, it's $300 for an individual. They also offer a state registration where the state pays for basically any medical director that wants to take this course. It's an annual fee, and they will actually put in whatever information on a state basis that we would want to have specified. So that would be an opportunity for us to put all the stuff from the medical board rules into this curriculum that they would then have to take. So that's an option. If we do it through the state or through some mechanism of a statewide registration, we will also end up getting back a list of the people that are completing this course. And so it's actually, in my opinion, a pretty good option. The folks that put this on is this Critical Illness and Trauma Foundation. How many in the room here were here when we were doing the ACS site survey? One of the folks that was on one of the surveyors is actually the principal for this particular company that puts this on. So he already knows something about our state. We know a little bit about him as well. And I also have actually talked to some medical directors in other states, state medical directors that have this course. And so if we end up going forward with this, and we're not looking to do anything except to throw this out here today, we would be talking more in depth about it at the next meeting. But there are some things that we will end up wanting to specify with them, just based on the discussions that I had with the medical directors from Montana and Idaho. But I think that this is a viable option, and I kind of bring this to the committee so that you guys can look at it and try to answer any questions that you have about it. I have no financial interest in these folks. I'm not an employee. I don't review for them. I'm not on their board of directors or anything. I get absolutely nothing out of this. Questions?
Would the intent for this be as a requirement for medical directors, as a option, as a pathway for them?
Well, there's been a variety of things that have been spoken of, and I think that actually the time is very ripe for us to recommend to the medical board that there be a specification in their rule that a medical director in Texas will take within a certain time frame, and then on an ongoing basis do it again in a certain time frame for a approved medical director's course, this being one option. I think the NAEMSP course is always a good option, and I don't know if there's others that are out there, but I don't believe that we should automatically say that this is the only option. You know, certainly 12 hours of CME and I'm not going to have to pay for it. You know, I think that that's probably something that a lot of folks would end up doing, just because it's not a very labor-intensive sort of course, especially having gone through some of these with a test password and everything. I think that their exams probably are not the greatest exams, and if we had the psychometricians take a look at their exam, it's probably not going to measure well, but if it gets people to where they're at least reading the information that they need to know, I think it's probably worthwhile. But yes, I would want it to be some sort of a requirement.
So this could be an alternative pathway as opposed to accredited fellowship completion and certification, things like that.
Well, unfortunately, that's not going to help us for decades.
Well, but in the pathway
Yeah.
Right.
as the future. So.
Right, and especially for the
long time.
rural areas. Yes.
Do you know of any states that do that already with this course?
Oh, absolutely. I don't have the list in front of me, but I know that I want to say West Virginia, I know Montana, Idaho. There are several scattered states. I can get you the whole list if you want. Yes.
Well, I think one of the points to consider is that if the Texas Medical Board is now actively looking at EMS medical directors, it's not a big leap to assume they're going to want something.
An approved course of some sort.
Right.
Or at
And-
least
and-
a
and-
list of approved courses.
Right.
Well, here's your list of states that are doing this now. New Hampshire, Virginia, Arizona, Montana, Mississippi, Idaho, Utah, Pennsylvania, and Alaska.
And for each state, they actually create that last segment for state-specific educational components. So, and I've toyed with it as well, and it's not it's a pretty well-constructed little format that is not really an onerous thing to go through. So, I think bring it to the group. I think at some point, if not today, then some other point, we should at least, consider coming to a consensus to maybe recommend this or something like this, table's open, as an option for medical director education. We have tried through the years and fits and starts and make it part way and then fall back, to push forward the idea of having some kind of a available, easy to get to, preferably internet-based educational program. And here it is, all nicely packaged and wrapped up.
Yeah, I think it's a great program and process, and certainly would be very supportive of it as one of those options. I mean, I think what we look at from a pathway process is, including fellowship, any MSP, medical director's course, the folks who've completed those sorts of things, trying to figure out what that list is. But this would probably certainly be one of the easiest paths, if you will, to have a formal review and process and tracking program. I think would be fantastic.
I think this is going to end up being an entire package because, I mean, if we're looking at numbers of services, requirements to get into the medical direction business, but then also continue. I mean, ACS has now that, if you're going to take care of a trauma patient, you have to have X amount of trauma CEs per. I mean, so the president has said in many subspecialties that it's the way to go. So I think it would be interesting to get a list of what each state has and find out what we need here in Texas.
You talked about a state paying for this or a package or an organization. Can you give us more specifics on that? We're members of TCEP, we're members of other organizations. What are our options there?
Well, it's really open. I think that probably with the budget concerns right now in the state, I'm not really sure that the state at a DSHS level can afford to take this. One consideration that I had was talking to TCEP, one was talking to TTAF, another was to the RACs. So there's a variety of ways. The cost actually to an organization would be fairly minimal. And I don't know, do you want me to go ahead and give what I've got as far as cost information, Maxie? I mean, for the initial year, the startup cost is $4,999 for the state. And that would be the startup. The next year, it would be $4,499, and it would stay at that level annually. And updates and revisions and everything to the state are included in that cost.
And when you say the state,
Well, a statewide level.
so it doesn't have to be the state.
No, it does not have to be.
You're shaking your head awful hard,
No.
by the way. Yeah.
No, I've had this conversation with Terry Sandel. Nell Sandel is a director for this organization. He's the one that came to do our ACS review.
Chapter grants.
And it has to be somebody that would represent whoever. It doesn't necessarily have to be the state of Texas.
And just to clarify what I thought I heard, that's $5,000 for all of any medical director in Texas to be able to take it?
Yes.
And customize it for Texas?
Yes.
That, even as a liberal arts major, that math is pretty easy for me.
Unless it's your checkbook.
I had,
$20 docs?
well,
Yeah,
yeah.
one way or another.
You know, I had one thought where it would work out to be about $250 for each organization for that first year, and then about $200 a year after that. So, you know, those are things to discuss because I want to present this at another time at our next set of meetings. Unfortunately, because of prior engagement, I was not able to make it here to last night to be able to present this to the group that I want to present it to as an option. So that's going to be on the agenda for the next meeting.
The TCEP annual meeting and the board meeting is in April, and I think this would be a good topic to take to that meeting. If the state and this committee is okay with that, and you can give me the information, I'll be happy to carry it there.
I'm fine. You get it.
Any objections to that? You want to go ahead and move it and second it and make it official?
I moved it, but I'll take it forward to TSEP
Yeah.
to see if there's anything that TSEP can or would do for this. There's also chapter grants available from ASEP to the states. Maybe this would qualify, but I think it's certainly something we should take forward. to
I'm not
TSEP.
sure why TSEP couldn't charge a fee
Right.
for each dock and then actually make money. Or at least not cost anything for them.
Well,
I guess it gets 30 docks and charge $100 a piece,
yeah, the one concern
or 50 docks.
with doing that,
Charge $100.
and I understand there is certainly always a concern of if something's free, then will anybody really do it because they don't see the value in it? Charge them $10 and well, then they'll do it. I do understand that, but at the same time, I don't want to make it restrictive for anybody to where, you know,
You have to be a member of TSEP to go through them or something?
right, or have it be that, you know, some doctor out in the middle of nowhere says, yeah, I can't afford $100 for that. You know, it's not really something that's gonna help me as far as my family practice or whatever it is. And I'm just throwing things out there.
Sure.
Just as consideration.
Yeah, I think we still officially have EPT, even though it hadn't met in years. We still have that ability to bring in non-TSEP members,
Sure.
so.
That works.
So we have a motion.
Second.
Smooth.
He has a motion.
Any other discussion?
I think it'd be good for 2 or 3 members to take the test or get online and before we make our next meeting to look at it in some earnest.
Do you think your discussions with the corporation would allow that for this committee to have access to their
Give me
program?
3 people, and I've actually got a sample username and password.
You sent that before.
Any other discussion? All in favor, say aye. Opposed by like sign? All right, Bobby, thank you.
Thank you, Dudley, for the clicker.
Okay, let's see. I see Dr. Kidd is here. You have cool stuff to tell us about TDMS?
Good afternoon. I wanted to clarify, on the agenda here, it states, update to Texas Disaster Medical System, which supports planning and activation of EMS resources in times of critical need. I wanted to clarify exactly what TDMS is. It's actually the collaborative effort of all ESF8, which is all public health and all medical care delivery services during a disaster. So we are coordinating both the public health side as well as all acute care and medical care delivery aspects of disaster care. We have been real busy over the last several months. We just finished our overview document. We're putting the final tweaks on it, which kind of talks about how the state will work with medical operations centers, how the Department of State Health Services and the DDCs with the Texas Division of Emergency Management will work with the local and regional public health and medical care delivery organizations throughout the state during a disaster. Department of State Health Services will be disseminating that very quickly. We're not exactly sure how that is going to be disseminated, but it will be coming to them, so y'all should be seeing that very soon. We have had a lot of discussion both in the TDMS group as well as the GETAC Disaster Committee on the pandemic planning process. Dr. Mitch Morber has put together a very comprehensive group of 55, I believe, 55 people around the state to do some pandemic planning and has done a phenomenal job. We had a discussion today that there apparently also are some regional groups in Dallas and Houston and probably other areas of the state that are basically paralleling the same planning efforts. And so we had a discussion today on how we're going to bring all of those planning efforts together to make sure that there's kind of one comprehensive planning effort that comes from the local areas up. And we talked about having some discussions specifically with Dr. Lakey and Dr. Valadez about what their vision for that is. And so we're going to be moving forward with the pandemic planning, hopefully including all regions of the state, in addition to Dr. Morber's statewide group. EMTF is moving along. We currently have 4 ambuses that are active, and the plan is by, I don't know if Victor's here, by July, Eric, we're supposed to have 13 ambuses around the state, so just in time for hurricane season. We've found some, with the RN strike teams, we've run into some roadblocks relating to liability, and several different areas are concerned about, the hospitals are concerned about lending their RNs to other areas and who's going to take the liability. So Denise Rose with the Texas Hospital Association has formed an RN strike team subcommittee, and will hopefully be vetting through some of those processes, and hopefully this year we will have RN strike teams in place as well with emergency medical task forces. And then finally, our big push right now is leaning towards education and training and collaboration around all the regions of the state with public health and acute medical care planning together. Just like we've been doing at the state level, the next level we think is to start getting regional groups together and start talking about how public health and acute medical care come together during a disaster planning. We're actually going to be rolling out kind of an overview and some regional discussions at the Texas Emergency Management Conference. And we also are working with our education subcommittee to develop kind of a 3-tiered education and training process that'll eventually hopefully be online, that everybody who's involved in disaster planning around the state can take a look at and take some of the, basically the operational courses. And then for people who want to be on specific teams, such as MIST teams, rapid assessment teams, cat teams, dog teams, bat teams, all of the teams that we have in the state, people who want to be involved in one of those courses will be able, or one of those teams will actually be able to take sanctioned training and education courses, hopefully sometime this year. So that's what we're working on.
Great. Questions for Dr. Kidd?
No, Emily, I would just say the Fort Worth, Dallas, the medical societies are the one really heading up the pandemic planning there. The
Right.
medical societies, yeah, going with support from the hospitals and then down to the primary care level. So it's kind of been a reverse downward up thing than top down.
Right, right, and that's the idea. We want to make sure as TDMS that we are supporting the local level up planning, but also that there's is kind of a similar planning process going on all around the state, and that different areas are not planning in silos, just like with everything else we do.
Mm-hmm. Great. Thank you for the update. Appreciate that. I believe I see Dr. Moore. We're back there in the back. Come talk to us about catastrophic guidelines, et cetera.
I want to thank Ellen for giving my part of the talks now. I can go back and sit down. We had a good presentation yesterday. We spent an hour on this topic. If this group would like, maybe in the May meeting, maybe we can spend an hour, go over this in detail. I want to emphasize that this is the worst event that could possibly befall the state or our country. There are 78,454 acute care hospital beds in the state of Texas. In a worst-case scenario, there may be 78,000 to 780,000 people needing hospitalization. In 1918, the pandemic that swept around the world in the first 24 weeks killed 2/3 of the 100 million people that it killed. 24 weeks is just long enough to develop a vaccine. So what we're talking about is essentially a medical holocaust. It occurred in 1918. What we want to do is plan ahead now and see what we can do to avert this disaster. We have discussed the guidelines, that the Utah guidelines, and as was stated, the crisis standards of care, they've been talked about by the North Central Texas Medical Association. They're pretty much in conformity with what we're doing. The children's guidelines are an issue, and we've discussed that. The issue becomes one of respiratory or ventilator usage, when to put them on, when to take them off. There is no good parameter to decide this. So we have a subgroup that's investigating now at Texas Children's with the ethicists, intensivists, emergency medical people, to see what the best mechanism would be and the best parameters that we can assign to develop these guidelines. And then we can take it up to the other children's hospitals, Dallas Children's, Cooks, and on through, I think there are 13 children's hospitals in the state. So that's what our plan is in that regard. We also discussed ventilators. Ventilators will be in short supply. So the question is, do we develop centers of excellence to take care of ventilator patients and maybe lesser centers to take care of supportive and palliative care for patients? How do we want to do this? We're not sure yet. I mean, this is still open for discussion. So these are some of the things that we've been kind of hitting on, and to see what the general feeling is. Let me go through my file for a minute. We talked about communication. As you know today, you have instant communication. You have Twitter, you have Facebook, anything that's drastic or adverse that goes on, you'll find out in about 2 seconds. We want to develop a communication center through the state such that we can have public service announcements, we can be on Twitter, we can have risk communications, so that anything adverse, at least we can counteract to prevent rumors and to prevent problems with the population. So we're trying to develop things along these lines. And we've talked with a number of stakeholders in that regard. Mass fatalities is going to be another issue. Mass storage capability. But one of the things that we've overlooked is pastoral care. And we're going to have a group of people meet to discuss pastoral care and how do we take care of the decedents. Also, how do we take care of an infectious decedent? And what do we do with families that have to be kept away from their loved ones because of the risk of infection? We want to develop some type of informed consent. Taking somebody off a ventilator is a really horrendous event, and I think people deserve the right to know before they go into this the modality of treatment they can have, what they can expect, and also the potential for an adverse outcome where they will be removed from a ventilator. And then we have to talk about force protection. Force protection not only for our healthcare workers, but for the critical infrastructure and our key resources. How are we going to protect those people that we find that have to support us in our electrical grid, our water, our sanitation? There's going to have to be some social worth mechanism put into the fact that these people may be qualified to have antivirals or vaccines before the rest of the population, and including our healthcare workers. So these are all questions we're going to have to decide. And this is going to take a larger group than just us. That's why we have so many people on the committee. We'll continue to add as people drop off, as issues are resolved. We'll bring more people in and go from there. I think that's pretty much it. Any questions?
One question that was brought up in the North Central Texas or the North Texas thing that really hasn't been planned or discussed about is like a non-invasive ventilation trial and bridge. With the portability and non-invasive ventilation today, I mean, we talk about ventilated patients, but really there's no discussion. There's never been in any of the protocols about a non-invasive trial. So I don't know if you guys have thought about that. It was asked to us, and I honestly hadn't
We've thought about that. CPAP, BiPAP, some other mechanisms. Again, we don't know how many there are. We don't know exactly. We can initiate a trial, certainly. If you have everybody's on a ventilator, you may not have any other alternative but to go that route. And that may be the direction we have to go in, first decide on the ventilators and then on other modalities if we don't have them available.
Yeah, I think that was the question they brought up about, trying to save the limited ventilator numbers for the truly needed patients. And obviously with the disposable CPAP devices now, that was one of the questions brought up. You could have a truckload of those, but then you have to have some sort of air source or oxygen driving source for those devices. So.
And of course, we may not have enough oxygen. So these are all questions that we'll have to look at.
Thank you.
Yeah.
We had a joint meeting with cardiac care and EMS,
We had a joint meeting with cardiac care, EMS, but not education, regarding requiring National Registry certification and the card courses for Texas EMS certified personnel. Most, if not all of you guys were there. It is one of our discussion items, and so I thought I would bring that to the table if anybody had anything new to add or.
I think they just sort of tabled it, but good ideas were presented. I don't know of anything that needed to be voted on at this point.
Was there a question about those who are not nationally registered going to the...
Yeah, that was a big issue in Texas since National Registry was on a requirement since, 2002 or something? So everybody prior to that.
But it's not required to maintain National Registry in Texas.
No, not at all.
So
a lot of
I think
them
a lot
had
of people
dropped
get it
out.
initially and drop it.
So me. So the from an implementation standpoint, that wasn't really discussed, but that's obviously a huge issue.
Right.
If nobody has any real burning desire for a consensus on that, thank you. We'll move on to the next topic.
Thank you.
No, not waiting. Item number 6 was the discussion regarding interstate aeromedical EMS transports and issues related to requiring Texas certification or licensure for those transport attendants.
I went to that meeting, and apparently there are times when we have helicopters that fly to Arkansas, and they are not allowed to pick up patients in Arkansas because we're not licensed in Arkansas, but we have tons of helicopters coming into Texas that we don't require to be licensed. So it's not an even Steven thing,
Are they picking up patients in Texas?
picking up patients along the border.
It
We have
started as a fixed wing issue.
Fixed wing
more than-
companies, yeah.
Yeah.
From Hugo, Oklahoma to Shreveport, Louisiana to all over the place.
Maxie's shaking his head. Something good to tell us?
The statute talks about them, if they come to Texas and pick up a Texan, then they're supposed to have a Texas license, but they can bring patients into Texas, but they don't have to have it.
It's a one-way deal.
I hate to be terribly picky about this, but because we have such a wonderful state, there have been times when non-Texans come to Texas and have medical emergencies. You're talking about just picking up anyone in Texas?
Yes, I'm
Okay.
sorry, yeah. I assume if you're here, you love us and you either want to be one or some of us are by choice, so I understand that.
Is there something that we as a committee need to say or do or comment on as far as that issue?
All the rules?
I think there's some national standards that are being looked at in terms of,
Is that already a rule?
Yeah, that's in statute, actually. So,
Well,
yeah, that's in statute.
I would say follow the statute.
But what?
Yeah, we've got to meet with that area of the state that's having issues and see what those issues are, because I heard two different things today. I heard one scenario where they talked about individuals bringing people to the state on a helicopter or fixed wing aircraft, and that our ground units are coming in and taking control of the patient. Well, who's in control of the patient? And those are the kind of things, as far as I'm concerned, should have been worked out before that doctor, that hospital even sent that patient to Texas and had all that worked out. But, so we just need to talk to those people who are having issues with it.
so if they meet at an airport and a nurse medic hands it over to an EMT basic to take them to the hospital, it's not logical. I mean, you're dropping in care. So they should maintain that same level of care all the way to the hospital.
Right. And you know, that I think that was one of the big issues that was brought forward, was that, you know, places you in a circumstance where someone without any Texas license certification is providing primary care in one of our Texas ambulances, and that's a big deal.
Yeah.
Or potentially a big deal. And
But
how do you address that?
When you go back to the rules and stuff and look at, it talks about, like, there's a caveat in there. It talk about EMS people, but then it also say for the good of the patient that a doctor, nurse, Indian chief can ride on there if they desire. I mean, if that's in the best interest of the patient. And it doesn't say in-state or out-of-state. So, I mean, I guess sometimes we just have to, I mean, if we're in West Texas, there's some of the places that have a variance and they're the ones picking the patient up and it's got lines, drains, and everything else, and all you guys are ECA and a driver, I'm assuming that team that's bringing that patient there is going to go with that patient until they get to a facility that can handle them.
I would assume that the intent of the statute was that we didn't want companies from pick a state that borders us, you know, extending into the state of Texas without obtaining the proper credentials in Texas to pick up patients. I don't think the intent, you know, whether it's applied or not, but I don't think that the intent was to say that, you know, somebody brings a patient in and they're having to go by ground to the definitive care would then lose all their care. I think that that's kind of assumed that they're going to go ahead and continue care at that level until they get to a definitive facility.
Please.
We have a slight variation of this on ground transports. I'm from El Paso, and we service pretty much the entire southern part of New Mexico, and we get many patients transported from New Mexico into Texas. New Mexico is a scope of practice state, and medical direction is provided by the receiving hospital. It's not that way in El Paso. And so we have an issue that we're trying to work through as to who provides medical control for them while they're en route if they have something happen in the ambulance. And so it's another issue.
Now, that patient's theoretically been accepted by a physician in Texas, correct?
That's what we're saying. That's our tact.
Makes sense.
But if it's a motor vehicle crash and it's a level 1 patient, then that's where they're going, and nobody's really accepted them. Except that we know that the level 1 facility is going to accept them. So,
I mean, my first blush feeling is that, you know, the medical directors for those agencies interacting around the border should have, you know, modifications to their programs to handle that sort of an interface. I don't know how you would regulate, you know, not only just New Mexico, but people flying into Texas from Oregon. You know, how would you maintain, you can't require Texas certification for the entire nation. I'm not sure.
As much as we might like one.
right.
Well,
Which of the 5
it
options
happens,
would you?
fixed wing, it happens, I guarantee, on a daily basis in the state. Because, I mean, the competitive world of fixed wing companies, when you're trying to move a patient, you put out an all-call, and various companies from not in Texas bid and will come into Texas and pick up a patient, take them somewhere else.
Floor is open. If folks have thoughts, concerns, other input on the issue, I don't see a fix other than the individual medical directors, you know, that deal with that kind of an interface, having provisions for that.
And there's some national standards trying to be, I mean, they should be reported out in the next few months about that, in terms of if you go into Texas or over a certain number of times, then you have to get a state license or something.
Yes, sir.
Justin Boyd from the EMS committee. I was the one that presented the question to this group last time. Kind of the thoughts and the feelings may have been the rule in our ground providers licensure states that appropriately trained or certified personnel. Maybe the clarification we're getting or looking for is somebody who's not certified or licensed in the state of Texas. Can they provide patient care in the back of a Texas licensed ambulance? Because if a patient requires pre-hospital care, can they only receive care from somebody who's licensed in Texas?
I think the question would be, are we talking regular or irregular activities? In other words, do they do this on an ongoing basis every time that they're on shift? Or is it something that just irregularly happens because of the situation?
Well, geographically, where I'm at, my closest level 1 facility is 200 miles away. My closest fixed wing provider is in 2 states over. So if a flight service that is CAMES accredited comes into Texas and picks up a patient, generally speaking, from the hospital, I have to go pick them up because they want door-in to door-in service. So I go pick up that crew, transport them to the hospital where they pick up the patient. They are not Texas certified. They do not hold a Texas license. The crew members don't. Then I take them back to the airplane where they get in and they fly the patient to a level 1.
In what state?
Texas. In Texas. Does that transport from the hospital to the airport, can a non-Texas certified person provide patient care? And you can even throw it to the other end, because they're transporting a patient from Texas to Texas. So when they hit the ground at the level 1, they have to have a ground provider pick them up. They're still providing patient care. Can they provide patient care into the hospital, into the back of that other ambulance?
Your service protocols, clinical operating guidelines, whatever you may call it, should have some provision for how involved can a non-service certified person, non-certified person be involved in patient care. And I think if your guidelines cover that, you know, as long as your medical director is involved in that decision process and is okay with it, then I think you ought to be covered. Anybody?
He's more concerned about clarification, the way the rules are written for the state. That provider, that ambulance service is at risk? Because how do you know that provider in the back is competent? That's where his question is coming from.
And exactly.
So it's
It-
more of a clarification of the way the wording of the rule is, because we discussed it last time, we have a protocol that deals with transportation and flight services. But that still doesn't change what the rule says about a competent provider.
The rule says several things, and that's why I say we have to use common sense sometime. If a doctor is going to ship a patient somewhere by any means, even if it's in a ground unit, they should know how they're shipping that person, and they should have an MOA or something in place to take care of that patient. If the President of the United States come in Austin right now, there's an Austin ambulance going to ride along with the President, but I guarantee you there will not be an Austin paramedic taking care of the President of the United States.
And I'm not going to disagree with that,
So,
but
I
the
mean,
problem is, I'm sure that these
There's guys with
physicians, when they
guns in there making sure that-
when they transfer a patient into that level 1, they have no idea who's going to come pick up that patient on the ground when they get to the receiving facility. Now, you may know who's going to transport them out, but these bigger cities, you may get 1 or 3. Now, the other question in my area that's more very specific to what you're saying is that we don't have the capabilities of staffing our ambulances with ALS or MICU capable paramedics at the time they go pick up the flight service. So we send them out there in a BLS component and pick that patient up from the hospital, even though the medic or the RN from the flight service is providing ALS patient care in the back of our ambulance.
You're simply the taxi.
Yes, sir.
Yeah.
And you're not billing at an ALS rate, you're billing a BLS rate, right?
Exactly. But it says in rule from the state that if it happens in the back of our truck, it is our responsibility.
Say the provider is responsible. The provider is responsible for things. They say you have to have 2 certified people on the ambulance, but then there's also another part of the rule that say, in the best interest of the patient, if you go to a neonate, like I said this morning, and your people it's an ECA, and they have a neonate team on there, that neonate team can take care of that patient until he gets to the hospital and stuff. It can do that.
But we're mixing multiple different issues. A medical director in Texas has no authority over somebody that's not certified in Texas to begin with. So it doesn't matter what I say.
That
There's
may
no
be true, but the
authority.
law doesn't say a Texas
Right.
nurse or it's a medical professional in there. It doesn't talk about a Texas certified. When they say on certain instances, for the good of the patient.
So if they come from Arkansas and they're doing a good job, let it go.
I just can't resist, but if Texas was a national registry state and surrounding states were national registry, we probably wouldn't be having this discussion with this lasting this long, correct?
They're still not certified.
I think his concern is legit, because I guarantee you if something happened in the back of the ambulance, that ambulance, that service and those crews will be named, no question.
They will be investigated. Now, we don't know what the
Maybe
outcome
not.
would be. There will be an investigation. That's true. There will be an investigation. If the driver turns that ambulance over for whatever reason, or if the driver's on drugs and he turned it over, whatever, yeah, there will be an investigation. But the outcome, we don't know what it is until we see the actual scenario.
But there's still
it
the
goes-
civil liability that
Right.
That's going to happen regardless, because it don't matter whether you're in Texas or Arizona. The court's going to take over.
there's multiple issues mixed in.
Yes, multiple issues. You got a quick, easy answer for all of that?
Yeah, don't take the run.
Well,
I think if it's a state issue, let them cite a few folks.
at a certain level, I think Max is right. I
think
mean, it
you
comes
have a
down
ru-
to the individual service medical director. If they're not comfortable taking these patients, then don't.
But Dr. Ellerby, the other thing is when they're making transfers, there's a sending physician and a receiving physician. And there's a service that's providing the primary transport. And in the spirit of what you're saying, Maxie, it seems to me that there's an element within this where we're not going to be able to line out every single incidence of every single situation. But there's a sending and a receiving physician, and that patient is under the care of a physician, and it's a brief, you know what I'm saying? It's a transitory, I just think there's an answer in here somewhere.
That's why they didn't resolve the issue.
Yeah.
Go for it, Eric.
Consider it a
I got a
disaster
question.
and all bets are off.
I actually had a more fundamental question that no one seemed to notice, I don't think. In Justin's, I may have misunderstood, but in Justin's example, there was a Texan who got picked up in a Texas rural hospital, and there was this ambulance discussion, and then this out-of-state, non-Texas certified entity flew the patient to another Texas trauma center. So we had a non-certified aircraft, Texas certified. I don't care about the ground part. I'm actually wondering, what about in the air between the Texas hospital to another Texas hospital providing air medical transport? I mean,
And that goes back to statutes say that you can't pick up a Texas person in Texas. So if they're using a non-Texas vehicle to come in and pick up a aircraft to pick up Texas in the state of Texas, that's not supposed to happen.
That's what I said, it happens all the time.
no, they can get
You know how many
certified.
helicopters we got around here?
Right.
Yeah, exactly. They will have to get a Texas certification if they're doing that.
That's outside the I-35 corridor.
Fixed wing.
That's outside the I-35 corridor.
That's what he's talking about.
But I think this comes back to the question of, is this a regular activity or an irregular activity? And if that fixed wing provider is regularly coming into Texas, I think they probably need to pursue Texas licensure.
They should. And that's what statute says.
Right.
If it's not a Texas provider. I say if there's not a Texas provider, they're picking up in Texas, they need a Texas license.
Sounds pretty simple.
Well, except that I think he's gonna say that his fixed wing provider doesn't wanna do that because they're two states away.
Well, then don't call them. Call another one.
Does a Texas licensed provider in another state, does their crew have to be Texas certified
Yes. Otherwise, they
If
wouldn't
they're
be able to
coming to
provide it.
Texas.
if they come into Texas?
Otherwise, they wouldn't be able to be a Texas provider.
Yeah, turn them in,
Can
Justin.
you help out by letting us know what that statute number is, so people can quote it?
When I see me after the meeting, I got it
Okay.
highlighted right here.
Okay, because, I mean, having that statute number where you can pull it up and show the hospitals or whatever, where, yeah, it would help out with people and clarification.
Got it right here somewhere, but I'm not finna stop talking. I got it.
Max, I have
Okay.
a question. So the service is not licensed in the state. What oversight or what bite does DISHS have to a non-Texas licensed agency?
Right.
That's another one of those catch-22.
No, I agree with you. It's a problem.
It's just like a non-certified person. We have no regulatory authority over that individual.
And you have to know that it's happening
Every day.
daily in Houston. You look at the tertiary care facilities there, people are coming in and picking up people
From where they
from
coming
hospitals going home, you know, from acute care there to other parts of the nation. Is happening every day. And there are providers coming in from out of state all the time
Out of
to
country.
do that. So maybe a push, an educational push through THA or someone else to the physician side or something else that maybe you need to ensure this. So, you know, maybe an article or several articles or whatever that cite the statutes so that physicians are more aware when they're doing these interfacility transports that they need to ensure X, Y, and Z
Could
before
be
they
part
sign
of
the
a
MOU.
question and answer of our magazine.
They don't read our magazine. Here you go.
You can't even,
All right.
putting them in the back of the magazine.
Okay, we're down to 4 minutes, 20 seconds, so we got a couple more things to get to.
I just want to say this is important to get clarification on because statute versus rule, the rules confuse this based on what Brett just told me the statute said. So, because the rules say you don't have to have Texas licensed people on your vehicle if you come from out of state. So it's very, very confusing and there's a lot of EMS providers. I know if something goes wrong, we'll investigate it. There's not an EMS provider in this room that wants to go down that path. We don't look forward to that to try to prove something. Or, well, maybe some of us do, but most agencies don't. And so we need help from y'all, from the state, the EMS committee, to really try to work to get clarification over this in our next couple of meetings.
Sounds good. We'll keep the topic open.
Ignorance is bliss.
Texas Health and Safety Code 773.045 B and C. That's 773.045 B and C.
Thank you. Okay, scooting along real quickly. EMS culture of safety.
Just in the interest of time, it's still open for comment, emscultureofsafety.org. Again, strategic view, please provide your input.
And I have looked through that myself, actually, and that's a really interesting document. I encourage everybody, including you guys. Again, that's emscultureofsafety.org. Okay, next item, we had an open one. If you will take one, pass that around. One of our action items was a position statement regarding hospital and EMS health information exchange. Jay Kovar did a lot of work on a statement down in the Houston area because Houston is one of those tough spots. Unlike nice, clean, tidy Fort Worth, Tarrant County, sometimes it's difficult to get medical information on patients, EMS patients, from the hospitals because the hospitals are somehow determined that that's a HIPAA violation. And with lots of services and lots of hospitals and lots of clerks, it's really a challenge sometimes to get outcomes on your patients. And so we decided we wanted to at least come up with some sort of a position paper regarding that. And I'll read through it for y'all's benefit. I'll do it very quickly. And I know in the end it's going to be kind of like, well, duh. But we figured having it as a voice from here would be good. So let me read real quickly. Position statement regarding hospital and EMS health information exchange from the GETAC EMS Medical Directors Committee. Emergency medical service is today one of the cornerstones of acute health care in the United States and is responsible for stabilizing, treating, and transporting seriously ill or injured patients. EMS continues to evolve the practice of acute care medicine in the out-of-hospital environment. However, despite major advances in this medical practice, many acute care hospitals do not view EMS as an integral professional part of the healthcare continuum. Operating under the delegated authority of the EMS Medical Director's license, pre-hospital providers are a direct extension of that physician in the field. Much as a primary care physician refers a patient to a specialist for specialty care, EMS Medical Directors refer their patients to the emergency department of the appropriate receiving facility. As referring physicians and as integral members of the continuum of care, EMS Medical Directors expect that appropriate information from the receiving specialists/hospital regarding patient diagnosis, outcomes, discharge summary, and critical quality improvement metrics be shared with them. This exchange of health is allowed by Texas State Health and Safety Code 241.153, subsection C. This portion of the code allows hospitals to share information with EMS services for the purposes of quality improvement, medical audit, and competency assurance without written authorization from the patient. Also, as part of the continuum of care, EMS medical directors and their agents are authorized entities under the Health Insurance Portability and Accountability Act of 1996 and entitled to protected health information pertaining to their patients. Accurate and timely exchange of health information between hospitals and EMS is critical to quality improvement for the agencies as well as for the individual providers. The attention to performance metrics related to coronary reperfusion time, stroke team activations and interventions, accurate and timely trauma and cardiac resuscitation management, and survival outcomes are vital to this new age of EMS and to the science of EMS that brings better, evidence-based care to patients. EMS and hospital information exchange must be seamless, taking advantage of this relationship, improving the continuity of care as well as the quality of service to our communities. Neither EMS nor hospitals should accept barriers to this vital exchange. On behalf of the Medical Directors Committee, et cetera, et cetera, et cetera. Submitted.
Revised.
You've already revised it?
This is from last meeting. I sent it to you.
Okay.
It took out a lot of this stuff.
I took a lot of it too and made it a one-pager because I knew that Bobby Greenberg wanted a one-pager.
It's got to be a one-pager.
Okay. All right.
I move we accept as revised.
You haven't even seen it.
Whatever you said is
Do you want it? Does it differ substantially from?
No, it basically takes.
Actually took out this paragraph about the Medical Practice Act.
What I did was I took out a bunch of the stuff that could be potentially inflammatory and make people quit reading, like hospitals don't consider EMS part of the continuum of care, that kind of thing. So I don't have a flash drive with me, but if somebody will do it, I can project it. Somebody got a flash drive? Yeah. I thought I sent this to you after the last meeting. I apologize. Does this have much porn on it, or just a little? All right, as soon as he. Oh, it does?
What's it? No.
Yeah, everybody has one of those.
But Robert, you said you didn't add anything. You only took out verbiage that would
Correct.
maybe give the wrong
As I
impression.
recall, let me, where's the computer that's attached to?
That's projected. It's over there, yeah.
While he's flexing his technological muscles, I'm going to hop over to item number 11. Just let you know that the EMS for Children presentation on the Essential Airway Equipment Project, we're not going to have that today. You should be aware as medical directors, you should be getting a nudge about a survey.
A nudge?
That will come directly to you. It's a Survey Monkey instrument. It's actually not prolonged and painful to do.
Not bad.
And so allow me to encourage you to take care of that and be part of
I
it.
agree, it's easy. And I sent it on to other medical directors as well, so.
But I promised Tony I would mention that, so that
Is
item
Tony
taken
here?
care of. He had to leave to go to another
Because
meeting.
I filled it out, but I'm still getting kick me emails. Can we
Yeah.
stop those?
Maybe they don't like your answers.
Maybe not.
No, I got an email that said that it's anonymous, so he has no way of knowing who's answered it. and who
Gotcha.
hasn't.
There's a small button there, delete.
Delete me from the list? No, I hit the delete, and I hit delete again, and I hit delete again.
I want to close mine.
Okay. Good to see you as always. Take care.
Move to approve.
Move to approve which one?
That one.
We have a motion on the
Second.
floor to approve that one.
Second.
We have a motion and a second on the floor to approve that one. Is there any discussion? All in favor say aye. Aye. Any opposed by like sign? No. Motion passes. Okay. We are officially out of time. As far as our agenda items, I'm going to call that end of it closed. Let me open the floor. If anyone has anything important we need to hear, please feel free to step up to the microphone.
I think number 8 needs to be discussed.
Absolutely.
Do you?
Yeah.
Okay. Well, discuss away.
Go ahead, Craig.
All right. The impact I think we all start to recognize and realize is the limitations of drug manufacturers in making availability of certain medications that are critical to our practice of EMS medicine delivery. And I think we're all aware that we start to see it. We've had to have some impacts in most agencies, and I think it's only going to get worse before it gets better. Probably for the primary component of this discussion is for our request or ask from dishes and compliance issues for either best practices or what you will tolerate in a semi-formal format for us, because we are at the point of maintaining patient care. We're having to change or exchange some of the standards that we've previously upheld, which are training and protocol development for a rapidly changing environment of what medications are available, such as benzodiazepines, which Valium is in very short order, and everybody switched to Versed. Now Versed is of short order. Ativan requires a refrigeration process for storage and things such as that. The opportunity, perhaps because of a risk-benefit analysis, to maintain and utilize the expired medications, which I think most medical directors would probably feel that that is a safer benefit than using or not using those medications if no other options are available to us. And certainly the impact on agencies with potential for inspections and having expired medications, changes in the protocols or medications that had not been available because a number of agencies aren't nimble enough to change those protocols on a daily or weekly basis and things. So I think that's something that we would like to ask from compliance members is either, again, a best practice process, thoughts, comments, but we probably even need to ask even a more formal process, I would believe as well, to communicate that to our agencies during this time of need.
Craig, I'll try to answer briefly because this is actually a national topic. The Medical Directors Council for NASEMSO is addressing this. The problem is that to extend the expiration date requires that the drug manufacturer make a request to the FDA for an extension of that expiration date, and then they have to specify apparently a certain lot, and then ship out labels that have a new amended expiration date. You know, we all understand, and we've been going over this with the Medical Directors Council, that there are many drugs that we know have shelf lives that are much longer than they're labeled. And the problem is that is something that the manufacturer requests how long to label those from FDA, and that is a process that the FDA has to go through. The Medical Directors Council is setting up a meeting with the FDA to try to get some sort of relief. The problem is that we don't know if that's going to be successful. On a state level, the state has no authority to change that outside of a declaration of a disaster. And I'm not sure that we can get the governor to do something
Well,
like
they have no authority to change the expiration date, but they can alter or change their compliance enforcement, recognizing the patient safety benefit to that. So, yeah, so I don't think that's reasonable to expect a change in expiration date, although Dr. Beeson has some alternatives to that process. But I think that's something that we have to have truly serious discussions about when we have a patient's actively seizing in front of us and we don't have a benzodiazepine that is available to us other than what perhaps is an expired medication.
I absolutely agree, and frankly, you know, my opinion would be to go ahead and give the expired medication with the understanding that it may have some loss of potency, so you might need to give a little bit more, but
if you get caught with it on your truck,
yeah,
you're in trouble,
and
so you can't even carry it.
And so, believe me, I've been in discussion with Maxie and those folks.
Well, I think it goes down to the question of enforcement, you know, because in a sense it's an off-label prescription. If a medical director, if I write a letter that I approve the use of expired Versed because there's no alternative, the question is I'm not worried about somebody coming after me. I'm more worried about the state coming after the entity, and that's where we're kind of.
I agree with you. Question, and the answer I got was, if it's expired and it's on your ambulance, it's a violation. So that's a problem.
And I think for a disaster, we're on the verge of a disaster because this is not ending anytime soon.
It's only getting more frequent.
How about it, State? You got any insight for us?
We can't overlook expired drugs. Now, what we do about it is a totally different thing. Our biggest concern is to make sure that the medical director is aware of whatever his people are doing. It's very important that we have documentation. Yes, if we get out there, we find expired drugs, we're going to document there were some expired drugs on the ambulance. We will do that. But then when you get to enforcement, we investigate, well, why were there expired drugs? And then that's where the medical director letter and the actual investigation comes. I'm not going to say what's going to happen. It will be an individual basis because some people don't have expired drugs because the provider don't want to buy new drugs and they keep them on there for a couple of years or so. Nobody here, of course, or listening on TV. But we don't want to get into a position where there are some providers that see it as an economic benefit to keep expired drugs on there. And it's not because the manufacturer is out or the distributor can't get it, stuff like that. So on an individual basis, we will take a look at it. We've had instances in the past where there's been shortages of drugs and we've had to deal with it.
That particular thing seems like a fairly easy question to ask. Is there Valium available? And right now the answer is no. So it seems like that's not an economic issue. However, if the issue is, yeah, there's plenty of Valium, everybody has Valium, why don't you? It seems like that's a fairly easy distinction to make.
Well, it is, but if you put out like a blanket statement, it's okay to use expired drugs. You know, why are you using them? It's because the manufacturer don't have. Well, that's easy. The FDA will let us know that. That's on their list and stuff. That's why I say we can use common sense as we come up to investigate and see what's going on. But we cannot say you can use expired drugs because we don't regulate the drugs. Our drug and food and drugs people, and I talked to them, and they said we can't say you can't use expired drugs.
Yeah, on a national level, the FDA and the manufacturers, they're not going to help us out with this situation. But I think that's truly where, if there is some directive and/or best practices that you can provide for agencies who want to be in compliance and aren't interested in the the economic component to that, I think that's helpful, because you've even identified just here that, yes, you're going to be identified that you've had expired drugs, and you are going to be investigated for that, versus if you have the appropriate documentation from the medical director, where is that filed? Is it in the protocol book? Does it have to be forwarded to the state? Those types of processes, I think, will be very helpful, minimize confusion, and allow us the flexibility that we need to help get through this critical time period, which I don't know how long the critical time period is going to last,
Well, that's
because it's a
another thing.
manufacturing issue.
And that's why we would make an agreement with the individual, the provider. You call me and tell me you got a problem, let's solve it. And
got a
I don't care
problem.
whether it's drugs or whether it's PD pass or whatever the case may be. I mean, we have to be realistic about it, but we can't make it.
My concern would be, because of the scope of this problem, is how you're going to track that and maintain that even at the state level, because this is not just a single agency issue. Is there any person here who has not been affected by this yet in this room? I mean, there's no hands being raised in here. So this is a significant scope and issue for us. And so I think that's where we certainly have to have that communication piece. And I don't want to seem too far out there in the wild of saying we need to use expired medicines all the time or anything like that. But I think there are going to be some patient safety risk and issues that are associated with this. And there will be some agencies who will choose, because of these type of comments, not to have expired medications on their rig to avoid any issue with compliance and things. So when that may be the best option available at that time.
Any chance of, say, guidance from above? Say some sort of a memo or note from the...
Message I was sending, if I put in memo, call your regional office and let's work through it. That's what my advice would be to you. And I would put that in a memo, call if there's a problem, call it, because...
And the advice would be, if you have to, say if the medical director has to issue some sort of a directive, X drugs for this time period may be expired but may continue to be used, that should be brought to the attention of the state.
Right, because
ahead of time.
we may ask you to put something in the protocol. We may ask you to put a statement here or there. It kind of depends on the circumstance. There are a lot of scenarios we can come up with, so it's better if that provider work directly with the compliance office and they work it out. I don't do inspections, so I'm not coming looking for them if that's what you're asking.
Can we go with don't ask, don't tell?
I don't say nothing.
It works.
I'll stand by my statement. You can't use expired drugs. But y'all hear me? You cannot use expired drugs.
Well, my question was more toward, this being a wide-ranging problem for the indefinite future. Would some direction or, consultation with the Commissioner of Health be useful? I mean, if we could, not some, wide, broad-ranging license, across the state, but some written, we understand there's a problem, we leave it to the individual medical directors to seek, best practices and maintain contact with the state. That way, the medical directors aren't entirely winging it on their own, liability-wise.
And we can run it up
That would be a nice thing. Anything else? Anything from out there? We are well over time. Dudley, sit down. Quickly, motion to adjourn?
So moved.
Second, and all in favor,